University School of Medicine, and Ange Polsinelli is an assistant professor in psychology in IO School of Medicine as well. We will be presenting to you a series of cases with rare Alzheimer's disease presentations, which so happens to be mostly from the longitudinal early onset Alzheimer's disease study, where we study young onset Alzheimer's disease cases with many of them with unusual presentations. And we'll be delighted to have Ange lead the presentation of these cases, and at the end, we're going to take a Q&A. We also have virtual audience. Welcome to you all. Don't hesitate to ask questions online, and I'll be monitoring those as well. Without further ado, I'm going to have Dr. Polsinelli take the stage.
All right. Good morning, everyone. So these are our disclosures, our policies. Photography is welcome. And then in terms of our learning objectives, we hope by the end of this presentation that you have a better ability to recognize the profiles of atypical Alzheimer's disease, that you're able to describe the neuroimaging and biomarker profiles of atypical Alzheimer's disease, and identify the appropriate workup for these variants. So this presentation is based on a paper that was published in 22 with Continuum, so we would direct your attention to that paper if you want more information and more details, particularly about these cases. So with early onset dementia, relatively rare. I think we all know that is a relatively rare presentation of dementia when it presents before the age of 65. So about 200,000 or probably more at this point, people in the U.S. present with an early onset or young onset dementia. And of these, a good portion of them actually have Alzheimer's disease. Another good portion of them have frontal temporal lobar degeneration, and then there are some other variants like Lewy body dementia, dementia due to stroke, and other causes of dementia. So early onset Alzheimer's disease, again, fairly rare and is considered an atypical variant of Alzheimer's disease compared to the traditional or late onset Alzheimer's disease presentation. As we already talked about, this is dementia that presents before the age of 65, or cognitive impairment that presents before the age of 65. And although the majority of these individuals will present with an amnestic syndrome, so a pretty classic memory impairment, there is a larger proportion of individuals who will present with an atypical variant of Alzheimer's disease compared to traditional or late onset Alzheimer's disease. So these include a language variant, which is the logopenic primary progressive aphasia, a visual variant, which is posterior cortical atrophy, frontal variants, which there's two, a behavioral variant due to AD, and a dysexecutive syndrome due to AD, and then a motor variant, which is cortical basal syndrome due to AD. An important component of early onset Alzheimer's disease is that this tends to be a fairly rapid progressive disease compared to late onset. So there's a pretty significant and steep decline, shorter period of time, and in that context, a quicker time to mortality as well. I should also mention, too, in this population, a diagnosis of Alzheimer's disease is particularly devastating because these individuals are often in the sort of quote-unquote prime of their life. They're contributing to a lot of societal and family responsibilities, including family income, caring for kids, potentially caring for parents or loved ones who have their own cognitive or maybe some physical disability. And so the onset of Alzheimer's disease at this point in time can be very devastating for the patient and for the families. In this context, because they're particularly in the context of atypical variants, early onset, these individuals oftentimes go misdiagnosed or they have a delay in diagnosis just because they are relatively rare and it's not necessarily something that people are looking for. or consider in their differential. So in this context, biomarkers are particularly useful for identifying Alzheimer's disease as the etiology of the impairment that we're seeing in day-to-day life. So this includes imaging biomarkers like MRI and amyloid PET in research settings, tau PET. This includes CSF fluid biomarkers, so A-beta 42, and tau, and that tau to A-beta 42 ratio. And then finally, again, more in a research context, the plasma biomarkers, which looking at blood biomarkers of phosphorylated tau. And so, again, only available at this point in time in a research setting. It isn't FDA approved yet, but these biomarkers are particularly important to get people on the track for earlier diagnosis. Because oftentimes the average time to diagnosis can be 2, 3, 5 years before somebody identifies. And then as we know with Alzheimer's disease, every year counts because there's pretty rapid decline over that time. And so people are getting connected to services much later, increasing burden on families and stress on families and patients and things like that. So now we've come to the portion where we're going to talk, or I'm going to kind of present a few cases. So a few of these atypical Alzheimer's disease cases. So the first case that we have is a 56-year-old female with 16 years of education. She presented with vision and navigation difficulties early on, and some memory loss that began approximately 2 years after the vision difficulties started. So in terms of the vision difficulties that she was having, her family was noticing that she was having trouble with depth perception in particular. This presented as when she was going up and down the stairs, she would miss steps or just not be able to kind of see the steps, and she ended up falling quite frequently. The depth perception difficulties also contributed to some problems trying to guide or trying to reach for things in her environment. And they were noticing, in particular, a pretty stark symptom was that she wasn't really recognizing or wasn't seeing things that were in her immediate environment that were readily apparent to everybody else. So her cell phone would be on the table, and she just couldn't see it, even though there was nothing over top of it. She just couldn't see it at all. Because of the vision difficulties, not surprisingly, she was referred for exams to make sure there was nothing wrong with her eyes, everything was fine, it was normal, which led to an appointment with neurology. So within the first year after the symptom onset, she became lost going to familiar places like the grocery store, her doctor's appointment. She would just get lost. She'd have to call family, and they'd have to either come and get her or try and guide her to get back to the house. Once she drifted, when she was driving, there were some safety concerns because she had started drifting in and out of her lane. And this drifting had actually resulted in her hitting parked cars on the side of the road, hitting guardrails and such. And so her family, understandably, was concerned about her driving and took the keys away. I already kind of mentioned the difficulty with visually guided reaching. So she would try and get something on the table, and she would miss, or she would knock it over because she didn't quite get there where she wanted to go. And she also had some difficulties writing in a straight line. She started writing sort of on a slant, an upward slant. In terms of her functioning day-to-day, her instrumental and basic activities of daily living were actually relatively okay, except for the driving problems that I mentioned, and that her family had to take away the keys for her driving. She also had some occasional difficulties with dressing. Right. So when she came into clinic, neurological exam found simultanagnosia, so difficulty seeing more than one object in her space. Optic ataxia, so that difficulty with the basically visually guided reaching. Some left-right confusion, problems with writing, and acalculia, and problems with calculation as well. She also demonstrated some trouble with reading, and this particularly, it wasn't that she couldn't read or didn't know what words were, but it was because she couldn't track the words on the page. She couldn't read in a straight line, and she was sort of jumping all over the place on the page. The remainder of her neurological exam was normal. And then in terms of her presentation, emotional presentation, she was irritable, she had some mild anxiousness, and she was depressed. Her MMSE was a 23 out of 30, and when she had a full neuropsychological evaluation, the most profound impairment that she had was in visual spatial perception and construction. So this included her copy of a complex figure, which was quote-unquote exploded, and I'll show you that in a minute. And this impairment in visual spatial functioning really underlied some of the other lower scores that she had on testing, in particular, like memory. So visual memory was pretty impaired. But relative to her verbal memory, which was only mildly impaired, we can see that there was an impact of that visual spatial impairment. Executive functioning was also mildly impaired. And again, that difficulty with calculations came up. And she had anomia. So on our Boston naming test, she had some difficulty coming up with the names. So this is the Ray Ostrith complex figure. So on the left-hand side, this is what it looks like for anyone who hasn't seen it before. And we ask patients to copy that figure as accurately as they can. And her copy is presented on the right. So you can see here that there is basically, you probably wouldn't be able to tell what that was that she was trying to copy. Just a note, the green is, she used the green pencil for a minute, then moved on to the blue pencil, then moved on to the red, and that's why there's different colors. But you can see here that there's some sparing of the details of the figure, but there really is no gestalt. There's no integration of the figure at all, and so we call this an exploded copy pattern. And this is pretty quintessential of posterior cortical atrophy. So in terms of her imaging, she had an MRI and not surprisingly found profound temporoparietal and occipital atrophy on that MRI. Her CSF biomarkers were consistent with Alzheimer's disease, so lower amyloid, higher tau, and that reduced A beta to tau ratio. And because she was part of LEAD, she got fluid biomarker, plasma biomarkers as well, and we see that increased p-tau 181. I mentioned she was already part of LEADS, and so she did get the extra workup in terms of the plasma biomarkers as well as tau imaging. So her amyloid imaging was consistent with Alzheimer's disease in terms of diffuse amyloid deposition, and her tau PET showed a similar pattern of uptake in the same areas that were showing atrophy, so that really posterior parietal and occipital lobe, and to some degree in the primary visual cortex as well. Again, that kind of a pattern is very quintessential or typical of a primary or of a posterior cortical atrophy, and you don't really see that in a lot of other syndromes, neurodegenerative syndromes. So the diagnosis, as I've said it several times, was PCA due to Alzheimer's disease. So there are three types of PCA. So there's the dorsal variant, there's the ventral variant, and then there's the caudal variant. Dorsal variant is mostly going to be affecting the parietal lobe, and so that's kind of the where or the action pathway. And so in this context, you're having trouble with construction, we're having trouble with visual perception. In particular, you might have features of Gerstmann syndrome or Blint syndrome. So like our patient showed the difficulty with calculations, some difficulty with writing, left-right disorientation, the simultanagnosia, some difficulty seeing more than one item at a time in space. And then you can also see limb apraxia and hemispatial neglect as well. In the ventral variant, so this is more of the temporal occipital pathway, so the kind of what pathway, you're going to see more problems with identifying objects by sight. So it's not that there's a loss of knowledge of what the object is, but just not an inability to recognize it by sight, preserved ability to maybe recognize it through sound or some other means. And you'll also see, most likely see prosopagnosia as well, so difficulty recognizing people by their faces. And then the caudal variant, which is relatively rare, this presents with a primary visual impairment because of the fact that it really does hit that primary visual cortex pretty hard. And so you actually get reductions in visual acuity and visual field deficits. And just a note at the bottom there that almost 100%, but 96% of cases of PCA cases are due to Alzheimer's disease. Although, the statistic says, once in a while it's not, and those are really interesting cases. Okay, second case, case B. We have a 55-year-old male with 20 years of education presenting with difficulties in language and memory over the previous 18 months or so. So his coworkers first were kind of noticing that he was having trouble following directions, following instructions. He was particularly at work, just not being able to do the job that he used to be able to do in an efficient manner. Although he and his wife sort of were noticing it, they just chalked it up to being a little bit stressed out or a little bit anxious. He then had difficulties that kind of progressed over time, and unfortunately, he ended up losing his job because he was unable to perform the duties of his job that he was supposed to be doing. So the difficulties with following direction and language were impacting his functioning in that way. Additional problems that he had included difficulties with speech articulation, so kind of mispronouncing some words. And then he had some difficulties with retrieval, as well as some difficulties with comprehension when information was a little bit more complex, or the sentence structure was a little bit more complex. He frequently had to ask people to repeat themselves because he didn't understand, or he couldn't respond in a meaningful way because he wasn't sure. And he had a lot of trouble going through documents, complicated documents like taxes, tax forms, and he was applying for disability, and he had a lot of trouble filling out those forms himself, so he needed assistance. He was independent in most of his activities of daily living, and the only things he needed some assistance were kind of like what we talked about, the difficulties with forms, as well as reminders for taking medications and attending appointments and things like that. So eventually, as it progressed, he stopped using the phone because it was just too stressful to use the phone because of those language problems that he was having. In terms of when he came to clinic and what we saw in clinic, his MMSE was a 17 out of 30. He had some, he definitely demonstrated some difficulties with language, and he needed sort of frequent repetition of instructions in order to understand what was being asked of him. And there was some difficulties with retention of information as well. So then he had a full neuropsychological evaluation, and the most pronounced difficulty was again in language. In particular, his naming ability, which was on the Boston naming, was a 29 out of 60. And just for a reference point for that, someone of that age, we would expect a mid to high 50 score. So it was quite low. He also had difficulties with sentence repetition, particularly as the sentences got longer. And he had some difficulties with reading non-words. So the test is basically a word that it doesn't exist, but if you know the phonemes of words, then you're kind of able to sound it out. And he had a lot of difficulty with that. He also, in terms of language areas that were spared, his grammar looked okay. He had spared single word knowledge. There wasn't a loss of word meaning or anything like that. But he did display some impairments in working memory, including problems with digit span and arithmetic as well. Visual spatial abilities were relatively intact. So in terms of his neurological exam, his speech was characterized by a lot of fillers, so using a lot of ums and uhs or likes, that kind of a thing. He had poor word retrieval, so he had a lot of word finding trouble when he was engaged in spontaneous conversation. A lot of circumlocutions, talking around words when he couldn't find a word. So knowing that there was a word he couldn't find, but just not being able to quite get it. And then he made a lot of phonemic and semantic paraphasias. So things like saying blant for plant, or helichopper for helicopter. Or I think one of them was, he said living tree for, I can't remember what the word was, but it was like a semantic paraphasia. And then behaviorally, his family was concerned that he might have some mild depression. In terms of imaging, his MRI showed, not surprisingly given the language problems, some higher left compared to right, perisylvian atrophy in the lateral temporal lobe there. In terms of fluid biomarkers in CSF, we're seeing again that pretty consistent AD pattern with lower A beta and higher tau, and that reduced A beta to tau ratio. Again, because this person was enrolled in Leeds, they had blood biomarkers, so he had a higher p-tau 181. Amyloid imaging showed diffuse amyloid throughout the brain, and then tau PET again showed a pattern that was actually a little bit more, so what I'm looking for, a little bit more present than what the atrophy would suggest, but in a very typical Alzheimer's disease pattern as well. So this individual was diagnosed with logopenic variant primary progressive aphasia. And as a note to, actually we could talk about it here, but as a note too with logopenic primary progressive aphasia, this is one of 3 types of PPAs, or 3 that we have classified currently. So in terms of etiology, again, this is like PCA, this is another one that tends to be predominantly due to Alzheimer's disease, but not 100% of the time. So these individuals often present with anomia or difficulty naming, poor word generation and sentence repetition, so word finding problems and that difficulty repeating sentences. And again, that gets worse as the sentences get higher because there is a significant working memory impairment and they just can't hold on to the length of that sentence over time. It's often accompanied by difficulties with reading of non-words like this patient showed, again, because it's kind of hitting that kind of like perisylvian area with the kind of inferior parietal lobe. It's kind of affecting that ability to process phonological information, so difficulty reading words that don't exist that require knowledge of phonemes. And then severely impaired digispan as well because of the working memory impairment. They typically have spared motor speech and grammar, which oftentimes distinguishes them from something like an agrammatic or non-fluent PPA. And they also have usually spared single word and object knowledge, which is the way that they can be distinguished from a semantic variant PPA or something of that nature. Importantly, for a diagnosis of PPA, that language impairment has to be present early, be the main problem or the main symptom that the person is having, and it be the cause of the functional impairment in day-to-day life. And so this patient met that criteria, given that the language was predominant, and was the main impairment that was affecting day-to-day life. Okay. So our third case is an 80-year-old male, so not someone who is in Leeds, with 16 years of education, presenting 3 years post-symptom onset for a second opinion about a diagnosis of behavioral variant frontal temporal dementia, or BVFTD. So his spouse initially noticed that he was having trouble with judgment and problem solving, and he had become really obsessed with these mail order scams kind of things. In particular, sort of these sweepstakes type things, like in the U.S. we have Publishers Clearinghouse, and he became very obsessed with playing that sweepstakes, and he had lost somewhere between $30,000 and $70,000 playing, or 2 scams or playing those sweepstakes. So within a year after his symptoms started, his driving became really erratic, and his family was concerned about his safety while he was driving. To the point where they decided it probably wasn't a great idea for him to continue driving at that point. He was also very irritable. He lacked empathy. So when family was bringing concerns to him, or when there was family strife, he just didn't seem to be too worried about it, which was atypical for him. He also developed some disinhibition. So acting inappropriately in social context, kind of loudly making fun of people on the street, that kind of thing. He started hoarding. In particular, he started stealing silverware and just kind of hoarding and holding on to silverware, and napkins, I think, was the other one. He also developed an obsession or a craving for sweetener in his coffee and just kept drinking coffee and sweetener a lot. And then there's also a change in his food preferences, and he became very obsessed with eating very particular foods. And I think it was sandwiches, bananas, and one more thing that those were the only things that he would eat. He developed other obsessions as well, so not just the scams and the sweepstakes, but he at one point developed an obsession with kind of adult coloring books, and he would just spend 12, 16 hours a day coloring in these coloring books. It seemed perfectly content to do it, but just that was the only thing that he was doing. And then he developed a delusion as well, a little bit later, or more recently to when he was seen, that he had a little robot dog, and he thought the dog was alive, and he would get very frustrated when the dog wouldn't eat or drink anything. So it became sort of a source of stress for him. So when he came to clinic, he had a MoCA of 3 out of 30. So really low score. His neuropsychological testing, not surprisingly, given a MoCA of 3 out of 30, just showed basically global impairment. Many of the tasks that we did had to be discontinued because he just couldn't engage with the testing in a meaningful way. However, even within that pattern, his visual spatial functioning didn't seem to be as affected as some other areas. His neurological exam was normal, except for some brisk reflexes that were more notable in the lower extremities than the upper extremities. In terms of biomarkers, his MRI showed basically patterns of atrophy in the lateral and medial portions of the frontal lobe. He did have an FTG PET that showed a similar pattern as well. He had CSF biomarkers, again, that were consistent with Alzheimer's disease, and he was enrolled in the IAD, or the Indiana Alzheimer's Disease Research Center, again, because he's 80 years old, so he was not eligible for leads. Amyloid PET, again, was consistent with AD, and Tau PET showed, again, that pattern that was kind of consistent with what we saw on the MRI in terms of atrophy, and FTG PET is that it was predominantly Tau uptake or Tau ligand uptake was seen primarily in the frontal lobes as well. Right. So this individual was diagnosed with behavioral variant Alzheimer's disease, and eventually pathologically confirmed to be Alzheimer's disease, and not BV or FTLD. So in terms of behavioral variant AD, this patient was originally diagnosed, understandably originally diagnosed with BV-FTD because of the clear changes in behavior and personality that he was displaying. It seems like a fairly reasonable diagnosis, but it wasn't until the collection of the biomarkers, the PET scans, the MRI, the fluid biomarkers as well, that it was determined that this was actually a syndrome that was due to Alzheimer's disease. So one thing to note about behavioral variant AD as well is that executive function difficulties seem to be out of proportion to relative other domains of functioning. He was fairly progressed when he was seen, so his profile was overall globally impaired, but typically catching people earlier on, it's going to show more executive dysfunction earlier on. Okay, case D, kind of a complement to the behavioral, to this behavioral variant AD. We have a 57-year-old male with 12 years of education presented with a second opinion about a functional neurological disorder. So his partner was more concerned than he was about the symptoms that were being presented. He was unable to follow conversations very well, so he would kind of get lost, be tangential. And he sometimes had difficulty maintaining his train of thought over time as well. He became fairly rigid and concrete in his thinking. Sarcasm kind of went over his head, metaphors, all those kinds of things he wasn't able to process. And unfortunately, it led to a lot of difficulties with judgment, with social functioning, with problem solving, and that kind of a thing. He was distractible. He was very distractible, and his organizational skills had substantially declined. And this was previously an area of pretty significant strength for him. So it was fairly noticeable when that declined. It was a pretty big change for him. So additional concerns included finding words when he was speaking, and some mild forgetfulness as well for conversations and things that had happened. Behaviorally, his partner described a lack of empathy as well. So again, that kind of just not really caring when maybe emotional things would come up for other people. And some compulsive behavior as well. Apathy, anxiety, irritability, and mild depression. So no necessarily significant personality changes, but some mild kind of behavioral neuropsychiatric changes. The cognitive problems had resulted for him, unfortunately, in job loss as well. So when he came into clinic, his MoCA was a 20 out of 30. His language had sort of a logopenic flavor to it, in that he had the trouble with the word finding. He had some troubles with just doing a lot of circumlocutions, working around words, and troubles with sentence repetition as well. He was unable to perform any of the Luria hand sequences during neurological exam, and he could not do any simple calculations either. So this is just easy kind of addition, subtraction kinds of tasks. The remainder of his neurological exam was normal. And on the neuropsychological evaluation, he demonstrated a multi-domain cognitive impairment with most prominent symptoms in executive functioning. So the executive dysfunction was the most prominent aspect, and it kind of underlied a lot of his other lower scores or lower performances on other tests. His visuals, in terms of visual spatial processing and visual spatial construction, that was relatively intact, particularly compared to this very pronounced executive dysfunction. So in terms of biomarkers for him, he again had an MRI that showed pronounced atrophy of the medial and lateral frontal lobes, as well as a little bit more of the medial temporal sparing. So they were not as prominent in terms of atrophy. He was enrolled in IDEAS. And he had no, because he was not part of LEADS or anything, we had no CSF results for him. But amyloid imaging did show it was diffusely positive, positive for Alzheimer's disease. And tau PET revealed an AD-like pattern in terms of that kind of like posterior parietal, but just, again, similar to the pattern of atrophy, not as prominent of a medial temporal presentation. So he was diagnosed with dysexecutive variant AD. All right. So in terms of dysexecutive variant AD, as I kind of mentioned, it's sort of a complement to the behavioral variant, but they are kind of distinguishable syndromes. So there's often a significant functional impairment for these individuals because of that very poor executive functioning that presents very early on and becomes very severe pretty quickly. And this is partly due, or this is due both in part to the executive dysfunction, but also poor working memory. And the poor working memory, similar to kind of the logopenic group as well, is that working memory portion just kind of gets knocked out. Poor working memory, poor executive function, again, underlies basically all cognitive abilities. And so when we don't have that working, it affects all aspects of our cognition and our functioning. So it's not a dysexecutive AD or dysexecutive syndrome due to AD is not typically associated with profound personality changes early on. But there could be some evidence of apathy that tends to be a little bit common. And not surprisingly, I think because of the level of impairment that people experience very early and oftentimes at a young age, misdiagnosis is fairly high, and this includes psychiatric symptoms. This includes functional neurological disorders, and as we kind of mentioned at the very beginning, it delays access to services and access to care. Family planning and things like that when misdiagnosis or delayed diagnosis occurs. And our last case, so this is a 57-year-old male with 12 years of education presenting with 2 years of progressive decline that recently impacted his ability to do his job, and he worked in heavy machinery, so he was no longer able to do that. So his spouse felt that memory problems were actually the initial symptom that he was experiencing, but then the symptoms had since progressed over those couple of years before they were seen in clinic. So he became confused a lot, and particularly in areas that he was actually familiar with. So even on his property, they had a farm on his property. He couldn't find his way to the barn. He couldn't find his way around the property. He had trouble also finding or navigating to familiar areas like grocery stores and doctor's appointments and things like that as well. Additional symptoms included problems with dressing, so dressing apraxia. So he would not be able to button his shirt properly. Shirts or things would be on backwards or inside out, and he couldn't seem to figure it out without help. And he had some difficulties with writing as well. So he had progressed to the point where he couldn't even sign his name in a way that was recognizable anymore. Decision-making was poor, and he was having trouble finding words as well. This is a common theme throughout many of these. He developed some irritability and some social withdrawal, some degree of personality change a little bit. But there wasn't any kind of significant personality change that you would see in something like the behavioral variant AD, something like that. He required, he was requiring assistance with a lot of his activities of daily living at this point, including things like we talked about dressing and things like that. So when he was seen in clinic, he presented with reduced speech output, so he just wasn't really initiating a lot of speech, and when he was, it was in, a couple of words at a time. He presented with problems with arithmetic or math, some left-sided extinction to stimulation for both tactile and visual information. He had a positive Babinski sign on the left, and he presented with myoclonus in both his upper extremities and mild right-sided limb apraxia and rigidity as well, and left-sided pronator drift. So his MMSE was a 6 out of 30, so again, very low scores, and based on that, not surprisingly, neuropsychological testing revealed global cognitive impairment. It was relatively more severe for executive dysfunction and visual spatial impairments, but most aspects of cognition were affected at this point. Or maybe not surprisingly, but unusually, he had trouble even doing the trail making test A, which for anyone who's familiar is you're just tracking and connecting numbers in order, and he just couldn't do it. Not that he was so slow that we had to discontinue. He couldn't track the numbers and where they were, which is fairly unusual. His spontaneous memory retrieval was extremely low, but his recognition was near perfect, suggesting there might be some sparing of retention, but that he was having a lot of trouble with the executive components of memory. So again, in terms of biomarkers, so his MRI showed left greater than right frontal parietal atrophy and left-sided atrophy of the putamen and caudate head. So this was suggestive of something like cortical basal degeneration. However, in addition, the CSF biomarkers did show, again, a fairly consistent pattern with something like Alzheimer's disease. Unfortunately, because he was unfortunately, we don't have PET imaging on him in terms of tau and amyloid because he was seen in clinic, so we didn't get those scans. But he was just after a year of being seen in clinic, he had already progressed pretty significantly and had gotten to the point where he was having trouble, recognizing his house and recognizing key family members, his spouse, his children, etc. And he was diagnosed with cortical basal syndrome due to AD. So cortical basal syndrome due to AD, it is extremely important for a thorough neurological exam for this one because a lot of the core symptoms are motor symptoms. And so these include things like the akinetic rigidity syndrome, so things like tremor, bradykinesia, are going to be prominent in this group of patients. Limb apraxia might also be featured, and cognitive impairment. So these are kind of the core features of somebody who might have CBS. Some additional supportive features include myoclonus, dressing apraxia, younger age of onset, particularly in somebody who has the pathology of Alzheimer's disease. It's more likely that they will be younger than someone who has cortical basal degeneration. And they're more likely to present with aspects of Gerstmann syndrome as well. Because the overlap between the presentation of cortical basal syndrome in AD versus cortical basal degeneration, there's so much overlap between those two things. Biomarkers are extremely important in determining what the actual underlying etiology, if Alzheimer's disease might actually be the underlying etiology here. Okay. So in summary, we have early onset Alzheimer's disease and atypical AD presentations can be very heterogeneous, and they're fairly understudied in the literature as well. We didn't even get into how heterogeneous each of these syndromes are in and of themselves, but we can just see over the span of these different syndromes that there's a lot of difference in how Alzheimer's disease can present. The utility in this situation, because there's so much heterogeneous aspects of these syndromes, the fluid biomarkers and the imaging biomarkers are extremely important in helping determine what the etiology of these syndromes are. And so finally, a plug for LEADS. This is where LEADS comes in. Large-scale studies like LEADS and others are going to be particularly important for helping us understand what these biomarkers look like in early onset Alzheimer's disease, in particular these atypical variants, to help us better diagnose our patients and better understand what treatment will eventually look like. So thank you very much, and we'll head into questions.
That was really, really, really fabulous, Ange. Thank you so much. We actually have one online question, well, now two, and I would like to address it because it gets into the unknowns of disease mechanisms and the regional vulnerability. So it's a long question. Actually, it's composed of three. Why does amyloid deposit spread in various areas in the brain and not others? Well, actually, amyloid deposits spread throughout the brain. Amyloid is not regionally focused as tau seems to be. So amyloid is pretty diffuse, and there aren't many differences between these phenotypes. However, your second question had to do with regionality of tau. So the tau protein in those special atypical cases follows the pattern of the disease presentation. Basically, the tau deposits are seen in the areas that are dysfunctional, and the same goes for atrophy. So amyloid's very diffuse, tau is sublimely regional, and we don't have answers as to why, but by studies such as LEADS and others, we might be able to disentangle that regional vulnerability of the cortex, which absolutely what factors drive that and why some people get one variant and not other is really important to the field, and we hope to have answers one day. Any questions from the audience? We're running out of time, but Dr. Polsinelli and I will be here to meet with you. Go for it. Mike 1?
It's all right. I've got a question. H. Peter from Melbourne. Thank you for a beautifully illustrated presentation. My question is, with the diagnosis of these co-pathologies or more complicated variations of Alzheimer's, how do these patients in the future require tau imaging? Because I can just envisage patients having a biomarker for amyloid, and a large proportion of patients might have amyloid and might not have this specific variation, might have a co-pathology. How would you differentiate that moving forward?
I don't know if you want to take that one as well.
Can you rephrase it? Because I was reading the other questions. So.
Okay. So my understanding is if, with co-pathology that's going on, basically will tau imaging be incrementally more useful in terms of diagnosis and differentiation? Is that, yeah, okay.
Yeah, tau imaging is incredibly useful in understanding, will be incredibly useful understanding disease mechanisms for these atypical cases. You raised the issue of co-pathology. That is certainly the case and is extremely frequent in late onset Alzheimer's, a little less frequent in early onset Alzheimer's. The extent to which co-pathologies affect the brain for early onset Alzheimer's is not yet fully understood. LEADS is an observational study that will follow these participants to death. So hopefully, if they sign up for autopsy, we get I applaud you for the great questions that we're asking ourselves too. One last question.
Hello, my name is Hans-Peter van Biel in Switzerland. I was just wondering, in my clinical practice, many of these patients you presented have the age around 60, so it's manifesting at a younger age. So can you speculate what does age do in this variance?
Like you've observed in your clinic, basically, is that we know that there's a higher prevalence of these atypical variants in early onset. We know that the early onset individuals have a very different disease progression than people with late onset. It's more rapid, it's more it's more aggressive, basically. I don't have a good answer for why it's the case that that atypical that's what these large-scale studies are trying to figure out. What is it about these atypical variants that seem to be